ever wondered why, like an emergency anti-seizure medication needs to work in a matter of minutes to save a life, but an antidepressant takes, a month to do its job?
Yeah, we totally have this built-in assumption about the timing of medicine, right?
Exactly. Like you take a pill for a headache, you expect it to vanish in 30 minutes.
Right, 30-minute stops.
But the timeline of how medicine actually works in your body is manipulated by some really serious hidden math. So, welcome to this deep dive. Today, we are looking at the mathematical choreography of how medicines get to work in your body and, crucially, how they stay there.
It's a fascinating topic.
It really is. We're unpacking the concept of loading and maintenance doses. And we've got a great stack of sources today. We're going to explore centuries of medical history, the underlying pharmacokinetic equations that basically dictate every prescription you take, and...
And a few genuinely terrifying cautionary tales.
Oh, yeah. What happens when that math just completely breaks down?
Because it's a striking contrast to how we usually view healthcare.
Mm-hmm.
I mean, we tend to think of taking medication as this simple transaction.
Right. Pill goes in, effect comes out.
Exactly. But the reality is far more like a tightly controlled and sometimes really dangerous negotiation with human chemistry.
Yeah.
It's not just an abstract textbook concept.
Mm.
The math we are talking about today is the literal boundary between a drug healing you and a drug causing severe, irreversible harm.
Okay, let's unpack this, because the biggest misconception we need to clear up right away is what these doses actually represent. I think the intuitive guess is that a loading dose is just a heavy initial hit.
Right, like an extra strong version of the regular dose.
Yeah, like you take 2 pain relievers to start, then 1 every 4 hours to keep it going.
Right.
But mechanically, they are entirely separate functions, right?
Completely separate.
So let's imagine your body as a bathtub. A loading dose is essentially dumping a giant bucket of water into the empty tub to fill it up to a specific level instantly.
I love this analogy.
It helps, right? And the maintenance dose is just leaving the faucet dripping just enough to perfectly match the rate of a leaky drain.
The precision of that bathtub analogy is incredibly helpful because dumping the bucket and setting the drip, they answer two completely different physiological equations.
Okay, walk me through that.
So the bucket, the loading dose, it addresses a concept called the volume of distribution, or VED.
Volume of distribution.
Right. It basically calculates how much drug is needed to fill the body's tissues and fluids to reach the exact desired concentration.
Okay, so the volume of distribution is the size of the tank.
Exactly.
And the dripping faucet, the maintenance dose, is answering the clearance rate. We are trying to figure out how fast the liver or the kidneys are eliminating the drug and how much we need to continuously pour in to match that drain rate.
You've got it.
Yeah.
They aren't just scaled versions of the same thing. They represent entirely different physical realities.
Right.
I mean, the loading dose only cares about the volume of the space it needs to fill. And the maintenance dose, it only cares about the speed of elimination.
Okay, but let's play devil's advocate. Let's say I'm treating a patient and I want to bypass the giant bucket.
Okay.
Maybe I'm nervous about a massive dose hitting their system all at once, What if I just start them on a high maintenance dose, like the dripping faucet, but turned up to a steady, heavier flow?
A lot of people think that.
Right. Because I'll eventually fill the tub to the same stable level. I'm putting more in, so it should fill up just as quickly without the shock of the bucket, right?
It is a super common assumption.
Yeah.
But it brings us to this fundamental, unbreakable law of pharmacokinetics.
The biological clock.
Yes, the 4 to 5 half-lives rule. If you skip the initial loading bucket and just start pouring a maintenance dose, it takes roughly 4 to 5 half-lives for the drug concentration to plateau at a steady state in the blood.
Wait, so since we know a half-life dictates the exact time it takes for the concentration of a drug to drop by 50% in the body, that 4 to 5 half-life timeline is a fixed biological clock.
It is absolutely fixed.
So it doesn't matter if I double or triple the daily maintenance dose.
Nope. That is the critical realization here. Changing the maintenance dose changes where the plateau is, but not when you reach it.
Oh, wow.
Yeah. So by doubling the daily dose without a loading dose, you'll just arrive at a much higher, potentially toxic steady state, an exact same delayed timeline.
That's crazy.
Right. If a drug has a half-life of a few hours, waiting 4 half-lives is just a day.
Sure.
But if a drug's half-life is measured in weeks, skipping the loading dose means the patient sits untreated for a month, regardless of how many pills you give them every day.
Just sitting there waiting for the math to catch up.
Exactly.
Knowing how unforgiving that mathematical rule is, it really makes the history of this completely wild. Because doctors were prescribing long-acting medications centuries before anyone coined the terms half-life or clearance.
Oh, absolutely. They were flying blind.
Literally. Take an English physician named William Withering back in 1785.
Classic example.
He was treating patients for dropsy, which we would recognize today as severe heart failure with fluid overload. And he used an extract from the foxglove plant called digitalis.
Right. And you have to remember, Withering didn't have pharmacokinetic modeling software or blood tests. He had nothing like that.
He just had his eyes, basically.
He relied entirely on clinical observation. And over a decade of treating patients, he noticed this really distinct pattern. To get a failing heart pumping effectively, he had to push the digitalis dose aggressively up front until he observed a clinical effect.
Or, in a lot of cases, severe signs of toxicity.
Yeah, unfortunately. But once he saw that physical effect, he would back the dose way down to a holding level.
He essentially arrived at the exact logic of a loading and maintenance dose entirely through trial and error.
Yeah, they called the process digitalization.
Which is such a wild term. I mean, the phrase dose until they show signs of toxicity is just a terrifying protocol for heart medicine.
It's incredibly risky.
He was effectively filling the tank blindfolded until it started overflowing and then dialing the faucet back to match the drain.
That's a great way to put it.
It worked, but the margin for error had to be just massive.
And honestly, the terror of that exact margin for error is what eventually forced the medical field to evolve.
It had to.
Right. As we moved into the mid-20th century, the shift from empirical feeling-based dosing to formal mathematics really began. Researchers in the 1960s and 70s, like John G. Wagner, Gerhard Levy, and Milo Gibaldi, they started formalizing the equations we use today.
Building on some older theories, right?
Yes. They built on earlier conceptual models by Torsten Terrell from 1937. He was the first to map how drugs distribute into different compartments in the body.
Yeah.
And the term pharmacokinetics itself was coined in 1953 by Friedrich Hartmut Dust.
And this wasn't just like an academic flex to put equations on a chalkboard.
No.
They were dealing with newer synthesized drugs with razor-thin therapeutic windows. The difference between a helpful dose and a lethal dose was shrinking rapidly.
Shrinking fast.
So relying on visual cues of toxicity meant people were getting hurt.
Exactly. If we connect this to the bigger picture of modern medicine, the foundational question really shifted. It moved from how is the patient physically responding to this dose to what is the precise mathematical concentration of this drug in the blood right now, and where is it headed?
Which brings us to how we apply that math to extreme physiological situations, because this is where it gets really practical. Let's look at amiodarone. It's an antiarrhythmic drug used for serious, irregular heartbeats. Now, its volume of distribution is often calculated in the hundreds of liters.
Yes, hundreds.
But physically, an average human body obviously doesn't hold hundreds of liters of water. So we are talking about a mathematical abstraction here, right?
Yeah, that's exactly it. Volume of distribution isn't an anatomical space. It's a calculated number representing dilution.
Okay, break that down for us.
Sure. Amiodarone is highly lipophilic, meaning it binds aggressively to fat and muscle tissue. When it enters the bloodstream, it doesn't stay there. It immediately sinks deep into the peripheral tissues.
So if you draw blood, the drug concentration looks artificially low.
Right.
Like it had been diluted into a massive invisible ocean inside the body.
Perfect analogy.
Yeah.
And to get enough drug to actually stay in the bloodstream and stabilize the heart, you have to saturate all of that fat and muscle first.
You have to fill an absolutely massive tissue tank.
Massive. And because that tank is so big, the drug's half-life is enormous. We're talking weeks to months. So if a patient comes into the emergency room with a life-threatening arrhythmia today, and you just start them on a standard daily maintenance dose.
You are waiting months for it to reach a stable, effective level.
Exactly. And they might not have minutes, let alone months.
Right. So that's why amiodarone requires aggressive loading.
Very aggressive.
We're talking hundreds to sometimes over 1,000 milligrams a day, divided over weeks, purely to saturate the tissue. Only after that tank is full do clinicians step down to a small maintenance dose.
Without that loading protocol, amiodarone would be practically useless in acute care.
It's like trying to fill a swimming pool with a garden hose while the drain is wide open. You need the fire truck first.
I love that, the fire truck. And we see the exact same urgency in modern protocols. Like, look at the 2020 guidelines for treating sepsis with the antibiotic vancomycin.
Right.
They made weight-based loading doses explicitly mandatory. In severe sepsis, waiting for a drug to build up is fatal. Hitting that therapeutic target fast correlates directly with patient survival.
Okay, this raises an important question, though.
Okay, what is it?
If loading doses save lives in emergencies and they bypass the biological clock, why don't we load every single medication?
Ah, here's where it gets really interesting.
Yeah.
Because the math assumes the human body is a perfectly functioning machine. But in emergency medicine, the machinery is usually broken.
Let's walk through an example.
Okay, let's say we have a patient whose kidneys are failing.
Okay, so the drain is clogged.
Exactly. Instinctively, a doctor might think, well, they can't clear the drug, so I need to shrink the loading dose so I don't accidentally overdose them.
I mean, that sounds completely logical. It sounds like a highly responsible, cautious move.
It sounds responsible, but it's a dangerous trap.
Really?
Yeah. Think back to the bathtub. The loading dose is determined by the size of the tub, right? The volume of distribution.
Wow.
For the vast majority of drugs, the size of that physiological tissue tank does not change just because the kidneys aren't filtering well.
Oh, the tub is the exact same size. The drain is just slower.
Yes. So if you shrink the loading dose out of caution, you fail to fill the tank. You undertreat the patient right when they need the intervention, most perhaps in the critical early hours of a massive systemic infection.
So in organ failure, you keep the loading dose exactly the same to fill the tank, and you aggressively reduce the maintenance dose because the drain is backed up.
You got it. Failing to grasp that distinction is basically a failure to understand the underlying kinetics.
Man, that's intense. But it gets even darker when we look at the historical application of warfarin, the blood thinner. This is like the ultimate cautionary tale in our sources today.
Oh, the warfarin story is wild.
Historically, the logic was straightforward. Thin the blood quickly, prevent the clot. So doctors would drop a massive loading dose of warfarin, maybe 10 to 15 milligrams, right up front.
And the logic fails completely because it ignores the nuanced biology of clotting.
How so?
Well, warfarin blocks a vitamin K pathway in the liver, suppressing the factors that cause blood to clot. But it also suppresses protein C.
And protein C is a naturally occurring anticoagulant, right?
Exactly. So it's blocking both the body's natural pro-clotting factors, A and DD, its anti-clotting factors simultaneously.
That sounds like a tug of war.
It is. And because protein C has a really short half-life, roughly 6 to 8 hours, it disappears from the blood almost instantly.
Oh, I see where this is going.
Yeah. But the dangerous pro-clotting factors, they have a half-life closer to 60 hours. They're still circulating.
So by dropping a massive loading dose to thin the blood faster, you wipe out the body's natural defense mechanism while leaving the clotting factors unchecked.
Yes. You have actively created a window where the patient is incredibly prone to clotting.
It induces a transient hypercoagulable state.
Which is the exact opposite of what you want.
Right. And if a patient happened to have a slight undiagnosed deficiency in protein C, that massive loading dose could trigger warfarin-induced skin necrosis.
Which is horrific.
It's a severe complication where microscopic clots form in the small blood vessels of the skin, causing tissue death. It is the absolute proof that trying to force the biological clock with a massive loading dose can backfire catastrophically.
It really is. Today, we bypass that trap by starting warfarin at a slow maintenance dose and bridging the patient with a separate, fast-acting injectable blood thinner until the warfarin safely takes over.
Which makes so much more sense.
But warfarin isn't the only trap. We have to talk about phenytoin.
That anti-seizure medication?
Right. Because it breaks the math entirely through something called zero-order or saturable kinetics.
Okay, this is another concept we need to unpack.
With most drugs, clearance is a linear process. If you have more drug in your blood, your liver processes it faster. It's a neat, proportional mathematical line.
But phenytoin operates differently.
Very differently. The specific liver enzymes that metabolize it have a strict maximum processing limit.
I like to picture this as a very popular nightclub with a strict bouncer at the door.
I love the bouncer analogy.
Right. So the bouncer represents the liver enzymes. In normal linear kinetics, if the line gets longer, the nightclub magically opens more doors and lets people in faster to keep the line moving smoothly.
That's standard clearance.
Exactly. But with zero-order kinetics, the bouncer only lets one person in at a time no matter what. If 50 people show up at once, or 500 show up, the line only moves at a fixed rate of one person per minute.
That analogy captures the mechanism beautifully. because once those specific liver enzymes are fully occupied, once the bouncer is maxed out, they simply cannot process any more drug.
Right.
So if a patient is on phenytoin and you increase their maintenance dose by just a tiny fraction, say from 300 to 350 milligrams,
Just a little bump.
right, just a little bump, the blood concentration doesn't rise proportionally. It skyrockets exponentially because the metabolic clearance pathway is completely blocked.
The bouncer can't keep up, so the drug just violently backs up into the bloodstream.
Exactly. It's a reminder that we are treating biological organisms, not just math models. If you treat zero-order kinetics with linear equations, you are guaranteed to overdose the patient.
Which brings us to the reality of modern clinics. I mean, textbooks are full of tidy equations for the average 70-kilogram human.
But humans don't fit into tidy boxes.
No, they don't. Take the debate over obesity. We established earlier that lipophilic drugs like amiodarone love fat tissue.
Right.
So how does a clinician calculate the volume of distribution for a severely obese patient? Do they use actual body weight, which might result in an astronomical dose, or an ideal body weight based purely on height?
This is a massive flashpoint in pharmacology right now.
Yeah.
Because it's not just a matter of size, it's a question of how adipose or fat tissue actually functions. Does the fat tissue metabolize the drug, or does it just act as a passive storage unit?
And it depends on the drug, right? We know that for hydrophilic drugs, drugs that love water and stay in the bloodstream, adipose tissue doesn't absorb them at all. So if you use an obese patient's actual weight for a hydrophilic drug, you are calculating a tank size that doesn't exist, resulting in a massive toxic overdose.
But if you use their ideal body weight for a highly lipophilic drug that does get absorbed by fat, the fat tissue steals all the medication.
It acts as a sink.
Exactly. And the bloodstream is left entirely unprotected.
The standard static formulas just struggle to handle these extremes. The margin for error is simply too high, particularly with potent medications in the ICU.
Which is why the modern shift to resolve this is moving away from those static formulas entirely.
Right, toward Bayesian, model-informed precision dosing.
Yes. Instead of relying on a generalized population chart, clinicians use specialized software now.
Which is so cool.
It really is. They input the patient's exact parameters, weight, renal function, and critically early blood level readings from that specific patient.
Oh, so it learns.
It does. The software recalculates the personalized kinetics in real time, dynamically adjusting the loading and maintenance doses. It allows us to map the unique mathematical territory of an individual's physiology.
That's incredible. So what does this all mean for you listening right now? Let's circle back to the question I posed at the very beginning of the deep dive.
The antidepressants.
Yes. If loading doses fill the tank instantly, and time is of the essence, why do doctors make patients wait 4 to 6 weeks for an SSRI antidepressant or a mood stabilizer like lithium to work?
That's a great question.
Why not just give a massive loading dose of an antidepressant so someone in a mental health crisis feels better tomorrow?
I know it's a profound point of frustration for patients. But the delay isn't a failure of pharmacokinetics. It's a limitation of neurobiology.
Okay, unpack that.
Well, with a heart medication, the drug's concentration in the blood is directly tied to its clinical effect. You fill the tank, the heart rate drops. It's immediate.
But antidepressants work differently. The drug reaches a steady state in the blood fairly quickly, actually.
It does. The delay is because the clinical benefit relies on slow, downstream neuroadaptive changes in the brain.
Right.
The drug has to alter receptor sensitivity, promote new neural connections, and fundamentally change how neurons communicate.
And that biological rewiring takes weeks. No mathematical loading dose can speed up that fundamental biological clock.
None. If a clinician were to push a massive loading dose of an SSRI, it wouldn't accelerate the mental health benefits at all.
It would just make them sick.
Extremely sick. It would simply flood the patient's system with unbearable instant side effects like severe nausea, tremors, or even serotonin syndrome.
Wow. So the side effects happen instantly because the blood tank is full, but the cure is delayed because the brain is still remodeling.
That's a perfect way to put it.
It's not just about filling the tank, it's about waiting for the house to be rebuilt after the tank is full.
The clinical effect does not equal the blood concentration. It is a vital distinction to make.
This completely changes how I view that little orange pill bottle, to be honest. To synthesize all this for you listening, loading and maintenance doses are fundamentally different mechanisms.
Entirely different.
The loading dose fills your body's specific tissue tank, governed by the volume of distribution. The maintenance dose matches your organ's drain, governed by clearance.
Right. And without a loading dose, You are bound by the unbreakable rule of waiting 4 to 5 half-lives for the drug to stabilize, no matter how many pills you take.
And the biological reality always supersedes the math. If the organs fail, fix the drain, not the tank. If the liver enzymes get saturated, standard linear math goes completely out the window.
As it should.
And as we saw with the warfarin disaster, trying to aggressively force the clock can trigger the exact catastrophic event you're trying to prevent.
It's all about balance.
It is. But looking forward, the introduction of Bayesian software and real-time modeling leaves us with a really wild thought to end on.
It really does.
Yeah.
As this software and eventually artificial intelligence becomes fully integrated into hospital systems, constantly pulling blood data and adjusting our individualized doses on the fly, you have to wonder about the future of these foundational equations.
Right.
Will concepts like volume of distribution and clearance become obsolete relics of the 1960s?
It's entirely possible. I mean, we've spent centuries, from William Withering's foxglove extracts to complex mathematical compartment model, trying to manually map the hidden choreography of the human body.
Well, now?
And now, we might just hand the whole process over to a black box algorithm that perfectly fills our tanks without us ever having to understand the math behind it. Thank you for joining us on this deep dive. Next time you take a medication, I hope you think about the invisible tank, the drain, and the silent biological clock ticking away inside you. Keep questioning the hidden science behind everyday life.